On this episode of 26 Minutes with Dr. Warren Siegel, I'm joined by an inspiring leader in maternal health, Mrs. Rochel Lieberman, the Midwifery Service Director in the Department of OB/GYN here at New York City Health and Hospital's South Brooklyn Health. Mrs. Lieberman's journey into midwifery is a unique and deeply personal one. She began her career in education, earning her first degree in Jewish education from a teacher's seminary in England. Her passion for childbirth education started when she coached friends through labor, and it wasn't long before she found herself exploring midwifery as an option for her own pregnancy care. That experience ignited a calling, encouraged by the midwives she worked with. Mrs. Lieberman decided to go back to school, earning a Bachelor of Science in Community Health and Issues, followed by a Master's in Midwifery from SUNY Downstate. She then became a board-certified and state-licensed midwife, dedicated over 26 years to both private and hospital-based practices, shaping the future of midwifery care. Since joining South Brooklyn Health in 2020, Mrs. Lieberman has been leading the midwifery service, ensuring that women receive high-quality, personalized maternity care. Her expertise and her leadership were recognized nationally when she was inducted as a Fellow of the American College of Nurse Midwives. In 2023, with a passion for patient-centered care and a deep understanding of maternal health, Mrs. Lieberman is here today to discuss a topic that is close to her heart: having a healthy baby. From prenatal care to labor and delivery, she will share insights on how expectant mothers can prepare for a safe and healthy childbirth. Mrs. Lieberman, it's such an honor to have you here. Thanks for joining us.
It's an honor and a pleasure. Thank you for inviting me.
Is it okay if I call you Rochel?
Sure.
Rochel, so tell us a little bit about where you're from. I talked a little bit about how you got involved and interested in midwifery, but can you expand a little bit more?
Sure. Growing up, we always went to doctors, and the word midwife was never part of our lexicon. However, after having a few children with OB/GYNs, I became interested, as you mentioned, in childbirth education and became certified as a childbirth educator, and became much more educated and aware of options that were available in women's health. And when I became pregnant with my subsequent pregnancy, I was unimpressed with the offerings in my area as to what type of practice I would be using. At that point in the early 1990s, there was no such thing as a solo practice anymore. It was very large groups of doctors, in which case you would never know who you were having at your birth or even at each visit. So I reached out to my childbirth colleagues, and they suggested, why don't you look into a midwife? And my first reaction was, what's a midwife? It was just a very foreign concept to me. So I did some research, and I found a practice in Mineola through Winthrop Hospital of midwives that worked as part of a faculty practice. I was in early pregnancy. I went with my husband to meet them and saw right away what a difference there was in the type of questions they asked me and the time they spent, the interest they had in myself, my family, my expectations for this pregnancy. It was just a whole new world to me. And by the time we walked out to the parking lot, I told my husband, we're using midwives. And he was a little more skeptical, but he became a quick convert by the time that baby was delivered.
So that's very interesting. So here you were introduced to a new concept as a patient, and yet that decided your future profession.
Little did we know, but during the number of years thereafter, that child was born in 91, and I would go yearly for my annual women's health visit. And in 1993, New York State passed what was called the Midwifery Practice Act, whereby there was a big change in the designation of midwives in New York State, whereby you no longer had to be a nurse in order to be a midwife. The belief stemming from the fact that physicians don't have to be a physician's assistant before they become physicians. Nursing is a separate career from midwifery. So if I no longer needed to go to nursing school, here I was in my 30s. I wasn't interested in spending those years in nursing school since I didn't want to be a nurse anyway. I could actually take certain prerequisites and some early training and then enter a program that was accredited by the American Midwifery Certification Board that would allow me to sit for the same boards as any other midwife in the United States. And they had such a program in SUNY Downstate. So as Stephen Covey says, you begin with the end in mind. And I saw what the prerequisites were to get into that program after thinking about it for a while, and decided to go back to school, do a bachelor's of science because I needed all the science courses. In the interim, after I already submitted my application, discovered I was expecting. It was just a 6-year gap from the previous birth, but I said, I'm not going to push it off. This is an opportunity that I really want to take advantage of. So I was accepted in 1997, 10 days before I gave birth. I came in introducing myself as the first visual aid. It was a part-time program for me, so it was a 3-year program. And I didn't start any of the clinical rotations till the following year, at which point my baby was 1, and it was a lot easier.
So you mentioned it was a 3-year program. Is that the training that all midwives get today?
Now it's a master's program, so there's a research component. And also what was happening was they were adding so many different parts to the midwifery training, in Downstate in particular, which was 11 months prior to my starting, including pharmacology, 4 credits. They felt that it was just too much in 1 year. So they changed it to the more typical college semester, fall, spring, and the part-timers had another fall, spring because we were doing less of a caseload each month.
So can you talk a little bit more about the training and how, if I decide I want to have my baby delivered by a midwife, how is that different than me going to an obstetrician?
Right. So I think you really have to go back to the basic meaning of what is an obstetrician and what is a midwife, because the names of those professions tell you something. Most medical specialties are, the suffix to them is ology, which is study of nephrology, pulmonology, cardiology, rheumatology, as opposed to obstetrics is not an ologist like a cardiologist or rheumatologist. He's an obstetrician. And it's a recent profession. It's only a few hundred years old because prior to that, for thousands of years, midwives were female practitioners delivering women all over the world. Only when Queen Victoria took a male midwife into her lying-in chamber did male providers start to get an inroad into this realm. Anyway, the word obstetrician, if you look at the suffix, which is ICIAN, it's similar to geometrician, electrician, which means to conquer an unknown force. And obstetraire, which is where the first part of the word comes from, means to stand before. So there's already an element of wonder in this process by which we bring life into the world. Midwife, however, is Old English, or actually Old German, and it comes from mit Weib, which means with woman. You don't have to be a wife to be a midwife. You don't even have to be female to be a midwife. There are male midwives as well. There was one in my class. There's a few out there practicing. But the fact is that the Weltanschauung of midwifery is that the experience is the mother's. We don't deliver babies. Mothers birth babies. So the focus is on the mom and her family, her loved ones who are with her, supporting her through this process. We also have a very strong belief that I try to impart to my patients as well as any students, medical or otherwise, that I'm teaching, and that is that we trust the mother. We ask her about her baby. How is her baby moving? When is her baby moved? Does the baby move more or less at different times of day? Learning how to recognize that when she or the baby's father or other significant person speak, the baby might start moving more because they're recognizing a voice that's going to be important to them. Helping her learn about her body, learning about the passage of birth and how it's going to happen, so that she can become empowered and she can start taking an active role in her experience.
Wow, this sounds like a very drastic change in philosophy it's not just delivering a baby. I love that. It's not just delivering the baby. It's actually working with the mom and having a healthy baby. So are there things that you tell women once they're pregnant in your practice, what they should be doing to have the healthiest baby?
Well, first it means getting to know your patient. And that takes time. And our visits are lengthy. For our first prenatal visit, we need to know what their family is like, what are their responsibilities, are they working, what kind of work, are they standing for long periods of time, are they a hairdresser where they're breathing in hair dye, and that's something we don't want them to do during pregnancy because it's unsafe. So what can they do in as a different part of the work in the salon if indeed they can find a different job to do. We also want to know emotionally, how are they, psychologically, even spiritually, how is this pregnancy affecting them? Is this a pregnancy that they have to get used to the idea? Maybe it was an oops and they weren't expecting to get pregnant. That might take a few months just to wrap their minds around. So there's a more holistic approach to their overall health and their pregnancy experience. It's not just come in and let's listen to the heartbeat and go home. Part of that requires a smaller caseload so you can spend more time. And understandably, a lot of obstetricians are so overbooked that they don't have that opportunity. And patients often tell me that when they went to a doctor, the doctor came in, put a sono on their belly, looked at the heartbeat, listened to it, measured it, and said maybe one or two words and left. So maybe the nurse practitioner saw them first or a medical office assistant, but there was no real give and take or real relationship building. And that's something that we really try to do.
So it sounds to me like midwifery is not necessarily an alternative to seeing an obstetrician. Is there ever times where you work with an obstetrician where, for whatever reason, it's both and you have to use a team approach?
Oh, absolutely. Yeah, because it's collaborative care. And while we are licensed independent providers in New York State, so we can see our patients throughout, we have prescriptive privileges, so we can write for medications or order tests or scans. We work hand in glove with our physician partners, whether it's maternal fetal medicine, high-risk doctors, or it's just a regular MD that we feel we might want to meet our patient and review if there are any particular issues that medically might need to be addressed. And we really do support each other. So what might happen is we'll co-manage, for example, if a patient is a gestational diabetic, which means diabetes developed during her pregnancy, and she needs additional surveillance of this baby, and therefore would be sent to a perinatal diagnostic center or some other type of high-risk clinic to be seen by a high-risk doctor.
So seeing a midwife is just an additional choice that every woman can make?
If there are midwives available, depending on, of course, things like insurance. If it's a private practice, if the midwife takes insurance, if the midwife doesn't take insurance, do they have out-of-network benefits? That's a whole separate piece. And the midwives who work as employees of a facility like South Brooklyn Health, obviously the billing is done outside of our clinic, but here, of course, we take care of any patient regardless of their ability to pay, so any patient can have a midwife.
So I know you brought some things that you wanted to show us that are very, very different than traditional medical practice when a baby is born. What are those things?
Okay, so I have a little bag of tricks here because we use visual aids a lot when we're teaching. So for example, when we see a patient who's maybe 8 months or 7 months pregnant, they have a large belly, and we are able to feel the position of the baby, and they don't know how we do it. So here's our model of a fetal model, which of course opens up to full size. But we will show the patient, after we've located the heartbeat and listened to baby, exactly how the baby's lying in her body. Show her where the head is, where the back is, why she feels a bunch of kicks on one side, because that's where the small parts are. And there might be something rounded up at the top, because that's usually the behind. So when they see it as a model, it becomes much more real. In addition, just taking their own hands and having them feel where the baby's head is. Mom can just put her hands on her own belly and push like this, and she's going to feel a baseball or a softball because it's very hard. In addition, we have a pelvis made out of paper mache, but it's very heavy, so I didn't bring it. And we can show them the process of birth and how baby goes through specific cardinal movements on its own through the contractions and the laws of physics that basically when you push one object through another, it has to take the path of least resistance. And we show them how the baby does those turns to manipulate and maneuver itself out into the world. So that's something that's very, very helpful. Can I put it here?
Please.
Okay, so we have a model of a baby, not only in the 2 rooms where the midwives work in the clinic, but also in labor and delivery. We have a couple of models. So we're able to show our patients who are coming upstairs to either be triaged and go home or to be admitted. Also, we can use this teaching model. Another thing we try to do, if it's a woman is in labor takes many hours and we want to keep her relaxed. So we have a diffuser. And we can put the diffuser, set it up with some water and essential oils. There are certain essential oils that are very helpful in labor, specifically lavender is a very relaxing scent. Some people like eucalyptus or mint oil. And when we put some of that, it kind of fills the area. We try to place it near mom.
So this is not a medication.
Not medication. This is just for ambience. And it helps them customize the room and make it theirs for the time that they are going to be laboring and birthing their baby. And our job is to create a sacred space outside that room so the mom can labor and birth her baby safely, securely, trusting in her body, which is, I think, the biggest hurdle, is for people to really trust that this is a process their body knows how to do. And throughout their pregnancy, I always tell them the best predictor of a healthy labor is a healthy pregnancy. And so if you've had a nice, healthy pregnancy, and midwives specifically see the low risk or moderate risk at most patients here, because that's what we need our doctor colleagues for, to see our high risk patients. And even something like this was a gift from a patient because there weren't enough chargers. So they bought me something like this so we could put multiple phones in and charge at the same time. It's just one of those things that nobody thought of when they designed the unit, but it's really helpful because now we can plug in the diffuser without having to unplug somebody's phone. And then sometimes we use flameless candles, set them up around the room, or in this box we have fairy lights. It's kind of hard to get them out, so let's just leave it like this. And then we can keep the lights down. And it's really special when a baby is born into the world and there are not a lot of bright lights because remember, it's dark in the womb. So when the baby comes out, they open their eyes right away and they start to look around. But if there's a very bright light trained on them, they're going to shut their eyes tight.
So this is available to all patients, or is
anybody who would want it? These are things that we keep in our call room so that we can offer them to our patients.
Obviously, some mothers have a very difficult pregnancy.
Sure.
May need to be delivered by cesarean section. That's still available, right, as a backup, or
yes and no. I mean,
if
it becomes a surgical birth, then it is endorsed to medical care because our obstetrician colleagues are surgeons and midwives are not. So they will go into the operating room, but we will often accompany them to support. So we will stand behind the mom next to her husband or partner. If he wants to come in, he or she wants to come in with them. And then we will be able to explain, interpret, and support so they know what's happening. And then when baby is delivered, if everything is going well, which we expect it to be, we bring baby over. And since mom is lying flat on her back because she's on an operating table, we'll use our other hand to help support the baby. And then we can do skin to skin and hold the baby right next to the mom so she can have that experience, which in an operating room is more difficult to achieve.
Now, you use the term skin to skin. Can you explain that? What it was?
So skin to skin is something that we hear in the breastfeeding circles. It is the concept of immediately after birth, the baby is placed on the mother's abdomen or chest and just allowed to rest there. And since most of the assessment of a newborn is done observationally, you don't have to grab the baby and look at it. If you see the baby's pink or crying and breathing well, they can't breathe. They can't cry if they're not breathing. Then most of the time, baby can just remain here. And what happens, studies have shown that their temperature regulates, their blood sugar regulates, and other systems all start to help transition more easily from womb to the world by being skin to skin, hearing the mother's heartbeat, hearing her voice, Remember, they heard both of those things inside for 9 months, and they slowly begin to adjust. And so it's a far cry from when we were young, and the television shows show doctors holding babies like this and slapping them.
Right.
Nobody does that anymore. In fact, we also don't even clamp and cut the cord right away. As long as it's baby's doing well, we wait about a minute or two when the bulk of any blood might have flown from placenta to baby, at which time we offer partner, they want to cut the cord, or we do it ourselves, and then baby has a little more movement because they're no longer tethered. But that's, and during that time, we also try to encourage mom to start breastfeeding, because baby, that first hour is a golden hour, as you know. It's the first period of reactivity. Babies are very alert and awake, and they're anxious to learn about their world. After that, they go into a deep sleep because they're also knocked out from labor and birth.
So it sounds like midwifery is a tested, true, been around for years and years and years. Why aren't we seeing more and more people being delivered by midwives?
I think it's education, getting the word out. We're fortunate that here at this facility, we have 11 midwives, 5 full-time and 6 part-time per diem midwives. So I tell my patients that when they come to labor and delivery, we're almost always covered 24/7. They can say, I'd like to have a midwife at my birth. As I said, we have a very respectful relationship with our physician and PA colleagues and nurse practitioners. It's a really nice team here. Not every H&H hospital has midwifery, but when they do, it enhances the patient satisfaction very greatly.
So I can come in when I'm in labor and say I want a midwife, as opposed to 9 months ago. I don't have to plan ahead.
You could, as long as there's a midwife currently working at that time.
But
Yeah.
It is true that midwives also would take care of me if I'm a pregnant woman for all of my prenatal
Right,
care,
because
right?
we work both in the clinic and
Okay.
on labor and delivery. So clinic is prenatal. In addition, we're board certified in GYN as well. So we do normal well woman visits. We do contraception, STD screening, from menarche to menopause. Really, we take care of patients for
And menarche, meaning
the beginning of their first period.
when women first start having periods. So you take care of
Their
women's
entire
health.
reproductive cycle.
So you take care of women's health. The relationship doesn't end when the baby is delivered.
Right. So we love to have our patients come back to us, especially for their 6-week postpartum visit when they're discharged from their experience, from their care, at which time we talk to them about what type of birth control they might be interested in. How do they feel about their family size? Are they thinking about having another baby at some point? Diet, exercise, screening for things like depression, making sure that they're healthy and they're feeling well, reviewing their experience. That's so important. Some of our midwives are now in a position where they can do what we call social rounds, and they go, after they've completed their clinic day, they go to the postpartum floor and just sit with patients and talk with them and review and go over their experience and how they felt about their birth, and what made them feel empowered and what maybe was disappointing, especially somebody who may have labored for many, many hours and for whatever reason had to have a surgical birth or a cesarean section. There's a certain amount of grieving that takes place, and helping work through that is essential in helping her recover from her experience.
So it sounds like this is another option for women, not just to have a healthy baby, but also another option to get good medical care for themselves. This is absolutely fascinating.
Right.
Thank you so much for getting the word out about midwifery services.
We have a great team. We have very, very dedicated midwives who devote their lives to this work. It's
Thanks.
a calling.
Thanks so much.
And that brings us to the end of our program today. Thank you for tuning in and learning alongside of us. For more information about our show, please visit us at www.zormed.com and stay updated with South Brooklyn Health by visiting us online. This broadcast was brought to you by Brick Media in partnership with New York City Health and Hospitals, South Brooklyn Health. Until next time, be safe and stay well.